Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Thank you for all coming here. I guess we have a little glimpse of sunshine here between all this rain we've had. So I think this is a very good timing talk that I'm giving because we are in the midst of a lot of respiratory infections this time of year, and I think the timing couldn't be any better because with the flu season that's amongst us and the other bronchial and respiratory infections, and including probably the more severe one, pneumonia. And when Deborah asked me to speak on this topic, I wanted to try to give a talk on something that's really relevant and something that we're all seeing, and we may have loved ones that are going through these illnesses, and how we can recognize it better amongst ourselves or amongst people that we help care for, and then how we can get them the medical attention that they need and how we should best treat them. Being a pulmonologist, as Deborah was saying, I get probably the brunt of this, and I'm probably at the busiest at this time of year, and a lot of the referrals come to me from primary care physicians, family practice, and internal medicine in regard to their patients with pneumonia and severe influenza and other respiratory infections. I see that we have a good gathering here today, so I hope that you guys can take this information and just impart the word. There's a lot of this is awareness, recognition, and then how we should deal with it as a whole, as a community. This is a significant health problem that impacts us here, especially this time of year. About 60,000 Americans die of pneumonia, and that is a significant number. Sure, a lot of the population that have succumb to pneumonia have multiple medical problems that predispose them to the gravity of this disease. But young people, healthy people, can get pneumonia too and can get quite ill from it, and needs to be recognized and treated early, and with effective medications that we have available. This is just a very simple schematic cartoon of the airways that I try to educate my patients on, as far as where infections could transcend into the respiratory system. It could be inhaled and then through the trachea, go through the bronchi, bronchioles, and then into the alveoli, which is the air sacs, where it can settle and can affect your respiratory system. It can affect breathing. Those patients that have asthma and COPD and emphysema are much more greatly impaired by it. And these are some of the signs and symptoms that we should all recognize. When you go seek medical attention, whether it be at the clinic or at your primary care physician's office, you should relay to them all of your symptoms, when your symptoms first began, days or even weeks ago, what your sputum production is like. Is there a heavy amount? Is there discoloration to it? Do you have any underlying chronic illnesses to begin with, which may predispose you? And then how are the health of others around you, at home, at work, at school, and where you've gone recently, especially around the holidays. There's more traveling, and the medications you currently are taking. You should also share your own health history. How severe is the cough? Are you having difficulty breathing with it? Associated temperatures and chills, which could be more significant. And then is there more shortness of breath than you're usually accustomed to? And then if other systems are involved, like your heart rate going higher because of the stress on your heart from the infection, and is there difficulty with pain involved when you cough or take a deep breath? There are many types of pneumonias, the most common of which is bacteria, so I'll review this first. There are many types of bacterial pneumonias that can occur throughout the environment. The most common are like the pneumococcal pneumonias. There's the Haemophilus influenza, and there's others. And it could occur on its own, or it could occur after a viral pneumonia, which weakens the immune system and predisposes the patient for a more serious type of pneumonia. If you've had like the flu prior to it, or a bronchitis prior to it, this may predispose the patient to having a more severe pneumonia. And the pneumonia differentiates from like maybe a viral or a bronchial infection in that the patient tends to be sicker. They have more weakness and fatigue. They have higher temperatures per se. They have chills. And there's usually more associated pleurisy, like pleuritic type chest pains, and more affected shortness of breath. And the phlegm is usually green, which is a change in the sputum that occurs. Viral pneumonias are common, probably more common than bacterial pneumonias. They say half here, but I'd say probably more than that. Probably 2/3 are caused by viruses. They tend to begin like a flu-like illness, like you're achy, you have headaches, you're just don't have the energy that you normally have. And as it progresses and it doesn't improve after 3, 5, 7 days, then you should definitely seek medical attention. Probably get a chest X-ray to see if there's more involvement in the lungs. Because if it progresses, usually the viral course runs its 5 to 7 day course. But if the breathing becomes more impaired, the patient ought to get checked right away, because once it gets settled in the lung, the more severe problem is it impedes the breathing so much that the patient might require oxygen right then and there, requiring them to be hospitalized. And worse yet, even the oxygen may not be sufficient for some time. And there's been patients, and I will show you like an algorithm, which severity category a patient will fall in if they have certain systems involved that they may even at times require to be in the intensive care unit for a time. So, those things have to be cautioned on. The fairly common type of pneumonia called mycoplasma occurs a lot in healthcare workers, people that are in enclosed environments for a prolonged period of time. People in schools, in enclosed environments while at the workplace, in large auditoriums. They run the risk, and this type of pneumonia is usually milder than the bacterial, maybe even the viral kind, because a lot of patients can actually still perform their normal daily functions, although not at their baseline pace. And they call this a walking pneumonia. It's usually more generalized, but not as severe. There are very good antibiotics to help this type of pneumonia, and there are tests that one can perform to diagnose this type of pneumonia. It's called mycoplasma or walking pneumonia. I'm sure some of you have heard of it, or your doctors have said that this is the type of pneumonia that you may have, or someone that you know may have had. It spreads pretty quickly because you're in a very closed environment next to people that congregate with each other. And like I said, they respond relatively well and quickly to treatments with the appropriate antibiotics. And the kind that are most sensitive to this is like the erythromycin type families, like Biaxin or Zithromax, or the quinolones like the Levaquins and the Avaloxes and the Cipros. And you may continue to have this dry cough because it causes inflammation in your lungs, and it could be a nagging cough. And if they've been on an antibiotic like, let's say, some type of penicillin, and they don't get better, that's probably something that should, speak in the back of your mind, that's saying, well, maybe this is something that is not your typical run-of-the-mill type of pneumonia. This type of pneumonia called fungi are less common, but albeit could be quite severe. You normally see it in endemic areas, in areas that, let's say, you could get the spores of the fungi to be aerosolized. A very common area not too far from us is called the San Joaquin Valley. And in the San Joaquin Valley, there's valley fever. And this type of pneumonia has come and haunted us here at Washington Hospital because they haven't responded to your normal, typical antibiotic regimen. And they have maybe traveled through there. That's one of the important historical questions that should be asked if they have not responded in 3 to 5 days to antibiotics. Have you traveled in a wind-blown area in the San Joaquin Valley? And common things that predispose these patients are if they've been, digging around the soil, if they've been working out in the yard, if they do, construction work and it's very windy. And this type of pneumonia are readily treatable by antifungal medications like fluconazole, and should not be, thought any less of than the other types of bacterial pneumonias. Although it's not heard of very often, but being this close to an endemic area, I think you could easily look it up on the internet, and physicians should certainly ask those questions and look out for it if they haven't their patients haven't responded. Then the pneumocystis carinii, or PCP, is a type of pneumonia that's caused only in opportunistic host infections that affect people like with AIDS or are immunocompromised from getting cancer treatments. This type of pneumonia is very disabling, and a lot of patients can succumb to this because it infects the lungs diffusely throughout both lungs, and their ability to breathe well becomes severely impaired. And a good majority of them will end up being on ventilators because they just can't breathe on their own. We seldom see that here because of our population is very low as far as the HIV community, but we do have cancer-stricken patients on chemotherapy that are immunocompromised, and when I'm consulted on those, I certainly try to look for it. Maybe I have to do a bronchoscopy, which is a type of endoscopy procedure into the lung, and try to get specimens to see if this type of infection has caused the illness in the patient that's in the ICU from this severe type of pneumonia. So if you have a pneumonia, what I was talking about earlier about these airways and these air sacs becomes filled with mucus. So gas exchange between oxygen and carbon dioxide is greatly compromised. The mucus fills those air sacs, and it also inflames it and constricts it. So a patient may have severe difficulty breathing because there's no capacity to exchange oxygen and carbon dioxide. In that bottom picture there, you can see that it's completely filled with mucus. And you try to cough, that's a sign to expectorate that mucus out, but because of the tenacity of that mucus, it could actually be sticky to the airways and the walls of the bronchioles, and you can't bring it up. And the mucociliary escalator, which are these little hair follicles that are beating, becomes suppressed by this mucus, so it will not function properly. So you will need other means to try to loosen that up, either through medications, through nebulizer treatments, through oxygen, even through suctioning deeply to evacuate this as best you can. And this is obviously a very severe type of pneumonia. The airspace and the areas in both lungs are occupied by the pneumonia, not just one lobe or one segment. It's a diffuse bilateral double pneumonia. And a patient like this would obviously be in the hospital, probably even in the intensive care unit. This is what I was talking about the classification of pneumonias. I know it's kind of small and hard to read, so I'll kind of walk you through it. Let's say one walks through the clinic or the emergency room or the doctor's office, and they have the complaints of the things we talked about, the coughing, the shortness of breath, the fevers. So you want to categorize them. How did this come about? Did you aspirate? Did you get this because your immune system was weakened? Have you had all your shots, your flu shots, your H1N1, your influenza, your pneumococcal vaccines? So if that's all been screened, and let's say the patient is otherwise relatively young and healthy, and we use a cutoff age of about 50 or 55 because your immune system is much more robust at the younger age group as opposed to when you get older. And then you try to break it down into certain very severe conditions. Do they have any underlying cancer history or being still treated for cancer? Do they have congestive heart failure, kidney problems, liver problems? I would even put diabetes and COPD in that category. If they are no, then you could go down to the next box and you could see what their physiologic impairment are. Are they pretty coherent, capable, not toxic appearing? not that labored as far as their breathing. Their mental status is sharp. It's not like they've been dehydrated and been really weathered and worn out. Then you could assign them to a lower category, risk 1. They could probably, if they're young, healthy enough, be treated as an outpatient with 7 to 10 days and good, careful follow-up. If they're a little older with 1 or 2 other organ systems that have, medical problems, I would probably err on the side of admitting them at least for a couple of days under observation and intravenous antibiotics. If any of those get shunted to the right and they're all yeses, like they have multiple comorbid medical conditions, other diseases, they have very altered physiology, their heart rate's fast, their respiratory rate's fast, their oxygen saturation on the oximeter is low, their temperature is really, really escalated or really low, their blood pressure's not stable, they definitely get the higher risk, either high intensity hospital admission or straight to the ICU. And why is this important to categorize that? Because if you don't, outcome is greatly affected, because it has been shown that if they are categorized correctly and triaged correctly, they have a much more successful outcome, like shorter hospital stay, less debilitation after they leave the hospital, and most importantly, survival. If they get treated with the right antibiotics, with the right respiratory treatments, stabilizing of the blood pressure, your chances of a state that they don't either pass from the pneumonia becomes severely impaired if you don't follow this algorithm. There's been literature that supports that even in the emergency room, if the wrong antibiotic is chosen and it's been kind of like neglected for 24 or 48 hours, it can affect the survival of that patient. That's why, the front line has to recognize this quickly and get all the cultures so that the lab can analyze this quickly so that they can be on the right treatment, quickly. Within probably, I would say, 24 hours is a reasonable assessment. Because, if you have all these factors, age against you, certain diseases against you, smoking history, alcohol history, you've been hospitalized recently or even in the intensive care unit, you've been exposed to all these chemicals and pollutants, you've had surgery or trauma, all those, escalate your risk factors, not just additionally, but probably exponentially. Every time that, a patient walks in, especially this time of year, I'd say 90% of my complaints are respiratory. They're coughing, they've had a sore throat, they've had sinus congestion. So they have to be carefully examined. They have to listen to all quadrants of the lung, front and back, and make sure that they, take a deep breath or cough before, you can really get a clear assessment. Even have them say some things like 99 or A, and then you could see the difference in the asymmetry of the breath sounds. Because if you have a pneumonia or congestion, your sounds will be muffled or suppressed, as opposed to when you're breathing healthy and clear, the airways will sound completely different. This is another picture of a single lobe pneumonia in quadrant A. So that area is thickened and congested and inflamed and has an impacted pneumonia, whereas quadrant B, or the left upper lobe, has a clear lung field, no infection there, and then C, of course, is the heart. Lab tests that can be done besides the chest x-ray is a CBC, which is to look to see if the white count goes up, and that usually signals that the immune system is being activated to fight the infection. And then sometimes if the breathing is impaired enough, a blood gas should be done, or at least a pulse oximeter, to see how oxygen flow is and see how severe their condition is. Later on, maybe after a couple of days, to see how their breathing is, to see if they've developed some airway reactivity or sensitivity that needs further treatment beyond just the antibiotics, especially if they've had a history of smoking. Sputum is very helpful, but if they've been on antibiotics already, it may masquerade what really is there. The sputum may be suppressed because, let's say, they've taken some home antibiotics that they've had from before, like amoxicillin from a previous dental appointment or whatever. It may confound the appearance. So when the sputum is obtained, this is how it looks like under the microscope. This is the commonest type of pneumonia. It's called pneumococcal pneumonia. They look like little beads, those little double-shaped little beads that are in the middle of the field are the microorganisms. The pinker, redder things are like some of the normal saliva cells, the epithelium that is sloughed off usually when you have a lot of sputum. Complications that occur after a pneumonia settles in your chest, it could actually go into your bloodstream, called a bacteremia, where it's become disseminated throughout your body, and that's when a lot of the organ systems could shut down, even your kidneys, and patients in that state are quite sick. It doesn't often reach this state because your own immune system will suppress that, and usually you try to get medical attention quick enough that antibiotics will start working before this occurs. But once it occurs, it could spread quickly because it's in the bloodstream. And other complications that can occur from a pneumonia are fluid accumulation around the lung called a pleural effusion, which can sometimes suppress the breathing because it pushes down in the lung and needs to be drained either with a catheter called a thoracentesis or even with a chest tube. And occasionally it becomes so thick that doesn't even work and drain it, and it has to go through a surgical excision of all that pus in the lower portions of the lung, and that's a long recovery, though it can still be done, and patients can improve if that's done not too far down the road, so that they can have a chance to re-expand the lung that's been compressed by the pus in the lung. You can get an abscess, which is a cavity that fills up with pus. That usually can be alleviated by good suctioning and percussion and drainage, and sometimes a bronchoscopy to free it up. But on rare occasions, because it's so difficult, the antibiotics won't penetrate into that cavity, that a surgeon will have to excise an entire, close to a lobe of the lung, like it would be to remove a lung cancer. So the treatments, there are numerous types of antibiotics for bacterial, not too many for viral pneumonias, and for mycoplasma I already mentioned, and the fungal one I already mentioned. For the classification of antibiotics are fairly simple if you break it down into 3 or 4 categories. There's the penicillin family, which is like the penicillin, the amoxicillin, the augmentins. And then there's the sulfa, which rarely is used because they're not that effective, and there's a lot of sulfa allergies. There's the erythromycin or the macrolide family, which has the zithromax and the biaxin. And there's the quinolones, which includes the levaquins and the avaloxes and cipros. And then there's the cephalosporins, which could be like Keflex, Ceftin, Omnicef, Suprax. There's the intravenous ones that are like Rocephin if you're in the hospital, and each one you try to tailor to the type of bacteria that you're treating, and you can either do that from a general statistical category. The majority will have this if you're this age, or if you have this condition, which is probability. And then the more exact way is, of course, to obtain the sputum and to study it under the microscope and know exactly what you're treating. Just like a biopsy and a pathology report, you know exactly what it is. Is it scar tissue or is it cancer? And the treatments that you can use on top of the antibiotics is, of course, careful fluid management to hydrate the patient so they don't get dehydrated, handle the pains and the aches from the muscle aches, and also the pleurisy from the coughing, cough suppressants or expectorants, depending on what they need, and then hospitalization if they're more critically ill. Most importantly, get plenty of rest, pace yourself. A lot of times people want to go back to their usual daily chores and activities almost at the onset of slightly feeling better. Rushing the recovery usually is not a good idea because you're not ready, the body isn't ready. As long as you are down maybe a week, 2 weeks, it may take you that long or even longer to get back into your normal baseline shape. And then get a follow-up with your doctor to make sure that you can resume your normal activities, whether it be some more simple blood tests or repeat the sputum test, or even get another chest x-ray to show clearly that it's improving. Prevention is very important. I mentioned getting your vaccines. Everyone should have had their flu vaccines by now, and the pneumonia vaccines, and even the H1N1 if there's risk factors for that. And careful hand hygiene washing hands carefully with soap and water, at least for half a minute to a minute, getting all the areas. Of course, preventing things from getting bad by quitting smoking or never starting smoking. Eating healthy, moderate exercise. Some little tidbits that I know they teach at the school is to stay away from anyone. If you are sick, don't go to school. If you're at work and you have to, wear a mask, but usually probably not even that, but just don't show up till you're better. Cough into a tissue, never into your hands. Cough into your sleeve, because when you spread it from your hands, you could spread it to your eyes, you could spread it onto the tabletops, shaking someone's hand. So it's very easily transmissible if you just cough right into your hand. So those are just common sense tidbits. I already mentioned all these things on self-care. And these are some websites that people can get good, quick, layman's terms, what to do when you have pneumonias. And then you could enjoy this. This was actually before, now that the leaves are gone, and we're going to see new leaves soon. Now, how about the flu and influenza? We all are susceptible, whether you're young or old, healthy or compromised. And everyone has probably experienced some level or degree of it and have felt miserable. Well, what is influenza? Influenza is the common garden variety flu that we all see and goes through the cycle of from November to about March. You can be mildly impaired by it or severely affected by it. It's highly infectious, can spread rapidly, and this time of year everyone's enclosed, so you're even more susceptible to acquiring it. There are many strains, and it kills over 30,000 plus in the U.S. every year. The symptoms of influenza are fairly typical and not specific. I mean, if you have a headache, fever, muscle aches, weakness, you can all point to that as being probably the flu. And it can lead to respiratory symptoms because that's how it's transmitted, through airborne. And you can get that sore throat, the cough, difficulty breathing. And the incubation time, a lot of my patients ask, well, when do you think I may have contracted this? If it's the flu, it's probably within 1 to 4 days after exposure to a person that had given it to you. And this is the seasonal, stepladder approach. And we are right now at the eye of the storm, if you will. We're right there at the tip of the most common time of year, like late January, early February. And this is, over, the last 40 years. That's how it's kind of panned out. That's why we try to vaccinate our patients earlier, like around October, November. That way they can build their immunity in December, January, February. Now, some people say, well, why can't I get it earlier, like July, August, September? And I actually had a patient that wanted that, and I didn't have it yet. It wasn't available. So she had traveled to visit a relative in Illinois, and it had gone through there earlier, like September, and she got it. But she stayed there through the holidays and then came home in December, January, and got the flu in February. Well, her vaccine had worn off because she got it in September. It usually lasts about 4 or 5 months of immunity. So she learned a lesson that you have to follow, the demographics of where it is, and to be timely about getting your vaccination. So that's why we try to, follow the guidelines, and we've, pretty much done. I mean, you can still get it now, but you're not going to get protected till March or April, right? Because we're February. And look where it is there. It tails off, right? So you're actually not, you're going to make your patients a little sick with the vaccine and yet not give them protection because it wouldn't have built into their system yet. So how does influenza spread? It spreads like droplets: coughing, sneezing, talking, and touching, infected persons or surfaces, and even getting it on yourself. And this is a nice little chart. Who infects whom? Well, most commonly you hear about the flu getting passed on from little Johnny to little Mary because they're in at school, their immune system is still building, they're in very close contact, and they pass it on to each other at a pretty high prevalence. And they could pass it on to their parents, to adults. Less so to seniors because they're not in contact with them. Usually grandma and grandpa live elsewhere. And teenagers are a little bit less because their immune system's stronger. They're more out and they're not as enclosed, and they move from class to class, so it's not all in one contact form. And then adults in the workplace, because if they got it from their children, they can infect their coworkers. So the most common demographics for likely transmission is school, household, and workplace. You know, children to teenagers and adults have the highest prevalence. And you know, that's you know what we try to impart to our patients. So part of this talk is more for awareness, so that you guys know what the statistics are and the probabilities are, so you could actually pass it on to friends or coworkers. This is a picture of a influenza A virus, and it has a coat, a capsule, and the H and the N are the ones that are right on the outside, and that's where the attachment occurs and the penetration of the virus. And there are different types of, other types of viruses. I won't go into a lot of these because it's already past, like the bird flu, which was pretty common about 2 or 3 years ago, especially those traveling to Asia. And the flu has many different, types of, variations, and from different animal exposures. And now this year it's the H1N1 that is the swine flu. But it's not the pig themselves. They're like a vector. You could still eat pork and not be at risk. It's not passed through ingestion. And when the avian flu was occurring, that was more, you can get it from the feathers and the aerosolization of the feathers into the environment. Now, the difference between a flu epidemic and a pandemic is that we are worried about this H1N1 as far as becoming a pandemic, because that's reaching worldwide instead of just a community, which is what an epidemic is. And when it's worldwide, it becomes a pandemic. And if you put it in perspective, if you remember 2001, after the terrorist attack on the Twin Towers, anthrax became something that was circulating around, and government officials were checking their mail and everything, and actually 5 people died from the anthrax. And that was a big scare. I mean, it reached headlines everywhere. CDC was panicking. Then the West Nile virus was a big thing a year after that, and 284 people died. And then the SARS virus, which affected the Asian economy, when 800 people died. But all those things, as panicky and as scary as those imposed, it pales in comparison to just the garden variety flu. There was a 68, 69 pandemic that 700,000 deaths occurred, 34,000 in the U.S. And as I told you earlier, about 38,000 die every year from the influenza, virus. In 1957 and 58, there was a bigger pandemic, 1.5 million, and the largest one to recorded date was the Spanish flu back in 1918, when 50 million people died and about 600,000 died in the U.S., which was a huge number back in those days with no treatment, and just trumps what normally is occurring seasonally. Now, there are treatments for it besides the vaccine for preventative. Let's say one either got the vaccine but didn't get protected because of the strain, or they didn't get it and there's no longer an available vaccine in any of the clinics or the offices. There is Tamiflu, we've all heard of that, and before then there was amantadine and ranitidine, and then there's the inhaled form called Relenza. I don't find it very helpful to use the inhaled form because, one, I don't think people are doing it properly, and there hasn't been good studies to show very good efficacy. So I'm still using the Tamiflu for those that have come and saw, like myself or another physician, early enough that it can be beneficial. After 2 or 3 days, the benefits are not that great, even though you're spending money to get it. They say, well, I'd like to get treated at least still, because by then you worry whether the viral or the flu-like illness has gone into a bacterial, and it may be better to give an antibiotic instead of an antiviral medicine. So same thing as, pneumonia. I mean, and same thing as, any other infectious disease entity is try to be preventative. Vaccination, stay at home when you're sick, cover your cough appropriately, wash hands thoroughly, avoid you touching your eyes, nose, and mouth, and close contact with sick people. And the most important thing, and we stress that here at Washington Hospital a lot, and I'm sure at all the other hospitals, is very regular, thorough hand washing with soap and water, if not available, the hand sanitizers. And The hand washing technique is taught in a specific way because oftentimes you think you've thoroughly washed your hands, but if you look at this picture here, about 50 to 60% of the hand is not washed, like in the webbings and around the fingernails is frequently missed, and that's the most likelihood of transmission in those areas that are missed. And then of course, a little plug for the hand sanitizers, which you can always have available. It's very convenient to just put them in your pocket. And there's a big impact on any kind of a flu illness, that if you miss 7 to 10 days of work, if you're in the lower income bracket, you can be very impacted. And if you've been ill long enough, even a month or longer, even the higher income earners will be financially impacted by it. So it really affects everyone, from the schools to the financial area. And this was published by the Harvard School of Public Health. Then lastly, I want to talk about the swine flu. Everyone's been hearing about it, been trying to get protection from it, and we know that there are available in a lot of the offices and clinics the H1N1 vaccine. It was a novel type of influenza that we saw this year, I think. But if you go back historically, maybe back into the 70s when Ford was in the office, there was a scare of the swine flu back then, and in fact, if I remember correctly, he even got the swine flu vaccine, and to say it was safe because people were worried about getting an illness called Guillain-Barré from that swine flu vaccine. Now, yes, there is a low likelihood, very low, of one getting the Guillain-Barré syndrome, which is like a neuromuscular paralysis from the flu or H1N1 vaccine. And we don't know. I've talked to neurologists whether it's the vaccine that did it or something else, the virus itself, because it is a live vaccine that's been attenuated, which means it's been weakened to be still causing antibody response in the body when it's given, but at a low enough level that it's not going to cause an overwhelming type of a disease process. It's just enough to get your immune system stimulated. And the U.S. government, had declared this a public health, crisis, and they were raising awareness in all their websites, and they were providing information and getting all the local clinics and the public health agencies, equipped to handle this. This was back in about October, November, and now it's kind of, slowing down and kind of riding that tail end like just a regular flu, and I think it's going to end sooner than the regular flu, as far as its peak. The first case that we heard of occurred here in San Diego, 2009, a little to our south, when it probably came from Mexico, and it has spread up to Northern California. As we know, we've probably had a dozen or so cases here at Washington and around the local community, and it's affected all age groups, but more young than old. Because, like I said, if this was popular or was in, a strained form back in the 70s, those that are over 50 either were vaccinated or got exposed and are kind of protected now, whereas the younger population may not have. That's why a lot of the physicians are saying, well, you don't need it. And they go, well, why don't I need it? Because I'm older, I've got lung problems, It's because of that, because they may have been exposed back in the 70s. Because you usually don't deprive the elderly and more frail from a vaccine because they're the most vulnerable. But in this case, that was the reason, in case anyone asks. Okay, just like influenza, it's always a serious illness when you contract one type of a flu or another, and the signs and symptoms are almost identical to the regular flu. Fever, sore throat, headaches, body aches, chills, fatigues, but they may have a little more GI symptoms like nausea, vomiting, diarrhea than the regular seasonal flu. And it is transmitted the same way through the respiratory droplets of coughing and sneezing. And there is, a vaccine available. It's not contracted by ingestion. And just like the other types of respiratory infections, good hand washing is still the key, and protecting you're exposing others, and staying away from public when you're still either symptomatic or at least 24 hours after symptoms have abated, like the fever is gone. What to look for in an emergency situation if you've contracted it, whether you should go to the emergency room or just see your physician, is that really the level of difficulty you are experiencing breathing. If there's extreme difficulty, you should go straight to the emergency room. If there's pain in your chest or abdomen, dizziness, lightheadedness, confusion, persistent vomiting, flu-like symptoms that don't improve or return, then you should go to the emergency room. And for pediatric populations, like for mothers that are concerned, if the child is having trouble breathing or is breathing rapidly, they turn blue-colored, cyanotic, aren't drinking their fluids, they're vomiting, all the things that normally portend a more ill child or person, merits their attention directed straight to the emergency room. And the CDC is still anticipating that there are more cases to come and more hospitalizations. But as I was saying, I'm seeing a downtrend now in February as opposed to November, December. And there's some CDC has some good websites, and I think we've all been alerted here at Washington and in our local areas and clinics and seminars that there's been good public awareness here, and that's why Deborah Garcia puts on a lot of these forums. Is a lot of it is for awareness and educational standpoint, because I know all of you contact your physicians when there's ever any signs and symptoms, because I know that the Washington community has really encouraged that and partnered with other offices and other clinics to all work together to try to garner the best health care that we can to our community here at Washington and Fremont Tri-City area. So I'm open for any questions. I know that's a lot to go over in just a short period of time, and I'm sure every Tom, Dick, and Jane has had these maladies over the years.
So let me come over with the microphone because we're videotaping this. Okay. Oh.
First of all, I want to ask for the pneumonia vaccination. Is it once for your lifetime?
If you're 55,
Yeah.
if you're 55 and older, you should get it. If you have any underlying, health conditions, you should maybe even get it earlier. But it's good for every 5 to 7 years. But once you've reached 65 and older, then once is good for the rest of your life.
The second question regarding to the H1N1 for the senior, is not really, at risk as much as the children and the younger groups. And right now it's already in February. Is it okay not to have the vaccination? And if we follow the precaution, like, the prevention, to wash your hand very well and do all the things, just like what you said. And just be very careful and not to have the vaccination.
Yeah, that's a very good question. I don't preclude some of my more elderly patients just because of the age factor, that it's not as common. But if there's any respiratory health problems that they have, like asthma, COPD, pneumonias, they have other conditions, heart problems, diabetes, that has a little bit of an extra risk factor than someone that's really healthy and they're in their 60s or 70s already. Those patients, I certainly will have them have the H1N1. If there's none of those and they're just because of an age criteria, I would say no, it's not necessary, and the risks outweigh the benefits. Because, like I said, you could have, low likelihood of that Guillain-Barré condition, or just being given an unnecessary vaccine and a virus in your body is not always the best thing to do if you don't need it. Just like medicines, if it's not needed, you don't want to just take it just because for the sake of taking it. So doing all the right precautionary things, good hygiene, eating healthy, sleeping, good diet, exercise, will all be as good or not, if not better, than having the vaccine. Because the vaccine is available, a lot of people will want or almost insist upon it just because they just feel that everyone's getting it, and I don't want to be the one that doesn't get it and then get, the illness. But I think you'll be fine without and doing those other things.
When you have the H1N1 vaccine, does it have any side effect after several days or weeks?
No, for all the ones that I've given it to, our own office staff, myself, and patients, I have not heard anything. There, was an asthmatic patient who thought her asthma may have gotten a little bit, a little more problematic from a management standpoint, but I believe it was secondary to another situation. No, there's very little even pain or discomfort upon the administration of the vaccine, and repercussions as far as a low-grade fever, which can sometimes occur after the regular flu vaccine, has not shown to be a side effect or occurrence with the H1N1 vaccine.
Yeah, about the flu vaccine, let's say if you had it last July 2009, how long will cover you? How long will
Like about 4 months,
Just
4 or 5 months, yeah. I don't know anyone that gives it in July. Where did you get it? Was it out of country?
I came from the Philippines. I
Okay.
got it last July.
Okay, it's probably-
Because we have the different weather there.
Yeah,
And,
that's probably why, yeah. Like about 4 or 5 months,
So I'm expired.
yeah. Stay good. You could get a booster. You could get another one if there's still any available, but then you won't get protected till April, May.
I'd like to find out, because we have a lot of vaccine, pneumonia, flu, H1N1. Can you take this all together in 1 month or something?
Yeah, you could. Different arms, maybe we would do 2 and then 1 maybe a week later or a few days later, But there's no contraindications to having multiple vaccines.
Okay, thank you so much.
If you get a vaccine in 1 year, do you have to take it the next year, or is it?
Well, not for the pneumonia vaccine, but for the influenza vaccine, yes. And next year, I don't know about the H1N1 status, but in general, yes, you should take a yearly vaccine on the flu vaccine.
I haven't taken any vaccine, so
If you're good, your health is good, and you don't get the flu, a lot of people feel that they're worried that they're going to get the flu because they get the vaccine. That doesn't necessarily mean that you need to get one because you haven't gotten one, and now that you've heard this talk on it, and that there's so many people that are at risk, so it doesn't mean that every person that is healthy needs one. I don't give it to my young healthy patients that have no medical condition. If they're like working in a healthcare environment, or they're a school teacher, or they're taking care of elderly sick patients, and they do have that exposure, then I would say it's good to protect oneself. But if you're working in an office that is relatively healthy, and your chances of being exposed to someone like that is quite low, no, I don't think it's something you should do. Some people just want to do it just for the sake of a checkoff list, to-do list. I know that I'm doing what I should, and I don't want to worry about it anymore. That's it. But that's usually you have to just look at individuals and their risks, and then use it in a wise fashion.
If you've been advised that you have a slight amount of asthma, can you do the breathing exercises that I was told to do?
Oh, yeah.
And will that sort of compensate? Can you increase your volume?
For sure, yes. If you do the right exercises, either through pulmonary rehab, and you use your inhalers correctly, and you check your peak flow monitors, which is kind of like a gauge, just like someone checks their blood pressure. It does determine how your volume is, and if your volume status is good, that means your risk of impairment from either the mechanics in the breathing that I showed you, where you're more at risk to get pneumonias or bronchitis because your volume is low. You will minimize your contracting infections and illnesses if you're managing your asthma correctly.
Apparently, there's no repercussions from the asthma. Breathing is fine, but just wondering, in order to prevent it from even getting it, if you didn't have but a slight case, if you could increase that volume with the exercises alone.
Yeah, you could, because if your test that you've had, like your pulmonary function test, show that you're 90%, 80%, but somewhere before you were diagnosed or told that you had asthma, yeah, exercise is fine, and you could you could alleviate even having to use your inhalers if you keep on top of that.
Breathing with the
Yeah,
pursed
deep breathing.
lips.
Yeah, pursed lip breathing.
Thank you.
Mm-hmm.
I just want to clarify something. If someone is almost 84, is diabetic, has been diabetic for a little over 10 years, has a heart arrhythmia, and has just been diagnosed with COPD, would it be dangerous for him to get H1N1?
No, I would recommend it for that person. I think there's enough risk factors there that that person can get a type of flu, whether it's an H1N1 or influenza, would be more impaired once they get it, and you want to prevent it as much as you can. Those are the type of people you want to prevent, because it's much more harmful to them than someone that didn't have those 3 or 4 conditions you mentioned.
So he should get the H1N1.
Yes.
Okay.
Regarding the antibiotic Avalox, does really give tendinitis or rupture of tendon? I mean, the
as a
risk
side
of
effect?
Avalox, yes.
I've never seen one. I know it's in the package insert, but I don't know the mechanism that it would do that. A ruptured tendon, you mean?
Yes. Or tendinitis?
Yeah, no, I haven't seen that, and I wouldn't really tell patients to not take something because that is written as a risk factor. Is that written in the package insert as?
Yes.
I would have to. I would have to say I don't know much about that. I haven't heard.
And the second question, how can you increase the volume? In case the peak flow.
Mm-hmm.
How can you increase it? What kind of exercise you should do?
Well, I mean, with common sense, I would probably build up to it gradually, either just walking. If walking is hard, it's something indoor like a treadmill, bicycling, stationary bicycling. So a lot of people say swimming is good, water aerobics. But anything that you're, increasing your cardiovascular system, you're also improving your volume, because you have to get the oxygen level up, to get that heart rate to go to a certain level. But, just to do it enough where you could get your heart rate to maybe about 75 to 80% of your predicted maximum, which is 220 minus your age. So let's say one's 50 years old, so that's 170, so about 170 times 0.75 or 0.8, so about 135 to 140, and that will always stimulate your breathing, because if your heart's going fast, the 2 organ systems, the heart and lung, will have to be interrelated to get the heart flowing and pumping. It has to get the oxygen to, generate the oxygen to carry to the tissues that are being utilized in that exercise. And then by doing that, then you're obviously increasing your lung volume, because you have to take the breath capacity in to get the oxygen to carry the, to the blood.
What about if you use a Qvar, daily? Does it really help, or it's going to give you a lot?
Well, Qvar is an inhaled steroid, and it's used in conjunction with like maybe albuterol. If you just have asthma, not COPD, it's good because it decreases the inflammation in the airways. So Qvar and Flovent and Pulmocort, all those things are anti-inflammatories. So if there's redness or swelling in your airways, that will enable that to be minimized, but it won't do so much as open the bronchial tubes, But Qvar is useful,
Can you use it for a long time?
Yeah, sure. I know people worry about side effects for any kind of a steroid-based medicine, but it's very topical, so it's going right into the area of need and not really going into, like if you took prednisone or by a pill form, that the steroids can cause, harmful side effects like diabetes or osteoporosis. The only thing you have to be careful of in using inhaled steroids for a prolonged period of time is maybe some thrush or yeast in the tongue or some hoarseness in your throat, because those are known side effects from it. But if you rinse right or use a spacer, those things are usually very minimal or none.
So so even the symptoms are gone, you still can use it for prevention, maintenance usage.
Yeah, that's a very good question. I think in asthma, since it's a very reversible condition as opposed to COPD, you want to do like step care therapy. So I would probably use the inhaled steroids as my first step, and use it as maintenance. But if they become, like you, for instance, totally asymptomatic and your pulmonary function tests are good, your peak flows are good, you could probably even reduce that to as PRN as needed basis. Because if you're mild intermittent instead of mild persistent, they say you don't even need to use inhaled corticosteroids on a regular basis for maintenance or prevention.
Any other questions? Okay, let's thank Dr. Chu.
You guys have been a great audience. I appreciate all the questions, and